Welcome back, everyone. I hope you had a nice, relaxing break over the last 20 minutes. We are going to start our next presentation in just a few seconds here. I just wanted to give a brief introduction. Right now, we're going to segue into our advocacy work, and in particular in the rare disease space. So I'd like to introduce Cassie Beisel. She's our Senior Director of Advocacy at the Melanoma Research Foundation. She came to work for the MRF in 2014 and has worked in many different areas, but the most impactful has been really her work in the advocacy space, where she has really led some tremendous initiatives. She has worked on both the state and federal level in terms of policy, helped the MRF with our research funding in terms of advocating through the Department of Defense, as well as regulatory issues while representing and engaging the interests of the melanoma community. As a 3-time cancer survivor, one of those being stage 3 melanoma, she is an extremely passionate advocate for the community, and I think you will learn a lot from her today. So with that, I'm going to turn it over to Cassie to lead us through a presentation on the advocacy opportunities for the ocular melanoma community. Cassie?
Thank you so much, Kylie. My name is Cassie Beisel, and I am the Senior Advocacy Officer for the Melanoma Research Foundation. Present advocacy opportunities for the ocular melanoma community. So what is MRF advocacy? Well, since 2009, the MRF has worked with advocates across the country on the local, state, and federal level, providing support to those living with and surviving melanoma, including its rare subtypes, and specifically for today, ocular melanoma. We raise public awareness of the disease, advancing research, and improving the quality of care and outcomes for the millions of Americans impacted by melanoma. The MRF is dedicated to working with lawmakers on the federal, state, and local levels for increased melanoma research funding, all types of melanoma, including mucosal, ocular, and pediatric, improved access to quality of care. We work with the Centers for Disease Control, aka the CDC, on skin cancer prevention activities. We work with age-restricted indoor tanning with the FDA, and we work on access to sunscreen in schools, but also much, much more. So the MRF works on 4 pillars of priorities. We work in research to advance groundbreaking research for melanoma patients, including ocular melanoma patients. We work in prevention, and since right now we're not really sure what causes ocular melanoma as of yet, so our prevention work works mostly on cutaneous melanomas and the prevention of melanomas, including skin checks, access to that, prevention would be, or early prevention and education would be access to dilated eye exams, ensuring that Americans are able to access that under their health insurance. We work on other access issues, such as access to biomarker testings, access to affordable healthcare, medicines and treatments. And then our 4th pillar is education, ensuring that the melanoma community is aware and educated on these policy issues in order to advocate more holistically down the road for access, research, and prevention. So first, I want to talk about one of the MRF's biggest priorities, which is federally funded research. And we do that alongside a program called the Congressionally Directed Medical Research Program, also known as the CDMRP. This is to ensure both scientific excellence and programmatic relevance. The CDMRP administers a 2-tier review process consisting of peer and programmatic review. This process was recommended by the National Academy of Sciences Institute of Medicine to enable a focus on targeted program goals while also capturing the traditional strengths of existing peer review systems. So let me break this down a little bit more for you. So regarding defense-funded melanoma research, as part of the congressionally directed medical research program. For a bit of a background, the MRF was always part of the congressionally directed medical research program under a peer review program, which included funding for 17 different cancers. The funding would come as a whole, and those 17 different cancers would share in that pot of money for groundbreaking research funding. So in FY19, the MRF was able to break free of that pot of different cancers and receive its own line item, which is called the Melanoma Research Program. And again, this started in FY19, and we were able to get $10 million. Previous to that, we had gotten $51 million from 2009 to 2018 that was invested in melanoma and other skin cancers. So again, now in FY19, we have gotten our own line item with the appropriation of $10 million. The current MRP funding, or for 21 for fiscal year, was 30 million. So from 2019 all the way to 2021 fiscal years, we were able to increase $10 million a year. Now for our fiscal year 2022, we are receiving $40 million. The $40 million has been included by the House Appropriations Committee as well as the Senate Appropriations Committee. There's one step left, and that is to pass it on both the floor of the House and the Senate through votes, and then be taken to the desk of the president so it can be signed into law. And then the appropriation will begin at that point in time being taken to the scientific community, as well as a very well-selected community of patient reviewers. The mission of this and the vision of this is obviously of this program is the vision is to prevent melanoma initiation and progression. And the mission is earlier intervention of these diseases to enhance mission readiness for U.S. military personnel and to diminish disease burden on service members, veterans, and the American public. So although this line item does come from the defense-funded appropriations, it's not just for service members, it's for the American public as well. So let's go to the next slide. So I also want to say that in the past 2 years, there has also been a new program that has been created for rare cancers and research, and that's called the Rare Cancer Research Program, or the RCRP. You will hear a lot of acronyms in here, and so I just want to make sure that we're breaking them down for you so it's easily understood. The Rare Cancer Research Program was launched in 2020 by Congress to support research on the prevention, detection, diagnosis, and treatment of service members, veterans, their families, and the American public in the rare disease community. Now, I will say that the Melanoma Research Program, which I previously talked about, those research proposals that come in through there do sometimes consist of rare disease proposals for ocular melanoma, the pediatric community, and the mucosal community. So although we do accept rare proposals within the MRP, rare cancers is important enough to have its own line item now. So with that, in FY20, Congress directed $7.5 million to the RCRP in the United States. And the fiscal year 20 Department of Defense appropriations. For fiscal year 2021, Congress appropriated $17.5 million. So again, now year over year, you're seeing that $10 million jump there. Now, this program is just because we're at 40 million and in the MRP and 17.5 for the Rare Cancer Research Program, it doesn't mean that it's always going to stay that way. And also it doesn't mean that it's going to go up. In fact, we could lose funding under that if there is little interest or little proposals coming through from our research community, if it's not advocated for from the patient population like yourselves and like the cutaneous, mucosal, and pediatric melanoma communities. And so with this, we really need to make sure to watch it every year, get increases where we can, protect a line item or the amount, for example, the $40 million that we have this year, ensuring that it's protected year over year so we don't lose money, but ensuring we can lose our line item altogether if there is a lack of interest and efficacy on the patient end. So really, it's these programs are really driven by advocacy and proposals on the science side, but also on the patient side. So let's talk a little bit more about how you can participate in these programs, both the Melanoma Research Program and the Rare Cancer Research Program within the CDMRP or Congressionally Directed Medical Research Program. To be a consumer reviewer, these are some absolute musts you must have. You must be a person living with or previously diagnosed with a rare disease, or if we're talking about the MRP, with melanoma of any sort, so whether it's rare or cutaneous. You must be a family member or caregiver of a person living with or previously diagnosed with a rare disease or any form of melanoma. You must be an active participant in advocacy, like a program like the MRF's advocacy program, outreach, or support an organization. And this is the thing that is an absolute must be nominated by that organization. So if you're interested in being nominated as a peer reviewer for any of these programs, you would then come to the Melanoma Research Program and ask for us to write you a letter of recommendation, which then we would give to the partners of the CDMRP, and they would review that application. And then based on that review, you would either be invited to participate, or they would say, you know, we reviewed your application, we don't have any extra slots this year, but they keep that application. So even if you don't get in for the next fiscal year, they'll hold your application and you may be invited in the year after that, or even the year after that. So let's get back to what you must need again. So you must have at least a high school education or its equivalent, such as a GED, be fluent in reading, speaking, and writing English, and you must represent the views of your community. So your community as a whole, and not only your personal perspective. So kind of putting yourself outside of your own personal experience, thinking beyond some of the areas that you may have experienced and thinking about the holistic experience of your community. And then lastly, you must have basic computer skills and have access to computer with internet connection. Below, I've placed a link, which is https://cdmrp.mil/RCRP/default. And that will take you to the CDMR website for the Rare Cancer Research Program. From there, if you're interested in the Melanoma Research Program, you can also find out more information about that, what is required, and again, how to apply. If you have any questions regarding this, again, please reach out to anyone at the MRF and they will be able to help you with that. I would also recommend reaching out to our CEO, Kylie Lapira, at klapira@melanoma.org, and she would be able to work with you as well to get over one of these recommendations letter. Again, this is an opportunity for the melanoma community at large to be able to offer their perspective on some of the most groundbreaking research that is coming out that may lead to the next FDA approved treatment for the ocular melanoma community. So to be part of that science, that review, could be a really incredible opportunity to bring the next big treatment. So let's talk about access now. So according to Healthy People 2020, which is a CDC program, inadequate health insurance coverage is one of the largest barriers to healthcare access. And the unequal distribution of coverage contributes to disparities in health across the US. Out-of-pocket medical care costs may lead to individuals to delay or forego needed care, such as doctor visits, dental care, and medications. And medical debt is common among both insured and uninsured individuals. Vulnerable populations are particularly at risk for insufficient health insurance coverage, as well as people with lower incomes who are often uninsured, and minorities account for over half of the uninsured population. So the MRF really tries hard to work on these access issues and make them equitable for all melanoma survivors, rare and cutaneous alike. Some of the access issues that the MRF works on the state and federal levels are, in order to protect and expand access to care for melanoma patients and its rare subtypes, ocular, mucosal, and pediatric, we work with Medicare and Medicaid specifically, and most recently, to make sure that we're working to cap out-of-pocket costs for those who are on those programs and ensure that when traveling over state lines with Medicare, that patients are able to access the same quality of care that they do in their own state. We work on access to clinical trials, understanding that the rare community doesn't have the same amount of clinical trials, and also with the understanding that, oftentimes there needs to be a lot of travel because they're not in different academic settings or clinical settings across the US. We work on that. We work with our partners over at American Cancer Society on access to biomarker testing to drive precision medicine. We work on access to prognostics, which are often FDA approved, but according to insurance companies are often still considered investigational, which would prohibit coverage from them with that in mind. We work on access to affordable drugs, and we work to ensure that patient experience and the patient journey is woven through that of pharmaceutical companies, as well as the FDA and organizations like ICER, which is the Institute of Clinical and Economic Review, which I'll go over in a little bit so you can better understand how that works. Now, the Cure Initiative did a report over the past few years working on patient-oriented value within the ocular melanoma community. My next segment of the presentation is going to be talking about what patient-oriented value is, what frameworks are within the community, and how patient-oriented value can really drive a change in access to diagnostics and prognostics for the OM community. So with that, let's talk a little bit about patient-oriented value. Patient-centered care has been recognized as a key element in driving high-quality, high-value treatment, and was incorporated into several initiatives within the Affordable Care Act legislation. Many studies have shown that placing patients at the center of care results in greater participation in clinical decision-making, as well as higher patient satisfaction and adherence to a treatment plan. Patient-oriented value, as I'll be referencing moving forward as POV, reports provide critical information on patient perspectives, on disease burden, care gaps, priority outcomes, and other factors essential to understanding value for current standard or standards of care, treatments in development, or any FDA-approved therapies. So why a POV report? Well, let me tell you. Uveal melanoma patients, or UM patients, their clinicians and payers face complex decisions on primary treatment of their tumor, determining whether to undergo biopsy or prognostic assessment, identifying a surveillance and follow-up plan for detecting metastatic disease, and deciding to participate in a clinical trial, and, if needed, selecting a therapy for metastatic disease. POV reports are undertaken to provide insight into the patient journey, articulate disease burden from the patient perspective, reveal real-world care gaps and communication deficiencies, and to better understand treatment priorities and perceived value from the patient perspective. Reports are designed to augment the patient advocacy organization's undertaking of the patient journey, care gaps, unmet needs, and real-world disease burden, as well as patient preferences and value perception on treatment and symptom management options. The hope that comes with scientific advances in is tempered by concern that the costs associated with genetic testing and targeted treatments could drive coverage and payment constrictions that limit access for patients. So I'm going to talk a little bit more about patient experience identifying, as you saw earlier, air quotes, value. As of this report that I'm about to share with you, 2 adjuvant therapeutic regimens are under clinical trial development for patients at high risk for metastases from uveal melanoma, again, the most common form of OM. Unfortunately, there are currently no FDA-approved effective treatments for metastatic and prognosis is poor, as many of you know. Median survival is approximately 4 months for those outside of clinical trials and approximately 10 months for patients participating in trials. The hope that comes with scientific advances in is tempered by concern, again, that costs associated with genetic testing and targeted treatments could drive coverage and payment constrictions that limit access for patients. The patient voice in identifying what value means on disease-specific basis is a crucial perspective that is often overlooked by entities evaluating the economic value of diagnostic and therapeutic interventions. These entities generally adopt a payer or societal perspective that may consider, but not fully incorporate, the patient perception of value. Patient groups are increasingly interested in translating their understanding of value into quantitative terms used by health economists, it's like a Monday morning over here, by health economists, so that treatment value incorporates patient perspective. So I've been talking about value and value framework. So it's important that I tell you what value and value framework are. Value frameworks have been developed to guide pricing and reimbursement decisions by key stakeholders in healthcare delivery. Yet, they are frequently criticized for not being sufficiently patient-centered and relying solely on data from randomized controlled trials to assess the comparative value of emerging therapies in disease states with multiple treatment options. When treatments emerge to address diseases that previously had no effective options to manage disease burden or improve survival, value frameworks focus instead on the incremental increase in survival, quality of life, and other metrics to determine whether the benefits of treatment justify its price or access. So now that I've explained that, let me tell you a little bit about what the report we did enables. So the report was designed to enable insights into real-world experience of patients throughout the treatment and surveillance processes, including participation in treatment decisions, access to genetic or molecular prognostic testing, understanding of metastatic risk, access to specialists with disease-specific expertise, impact of disease and its treatments on the quality of life, which we'll talk about in a little bit more, priorities and preferences throughout the patient journey. So the method of our report, so this report, and we had help from our pals over at Colorado Retina, we distributed the survey to 1,329 OM patients and or their caregivers via an email invitation. We received responses from 128 or OM patients, and which underwent a statistical analysis and contributed to the report. The statistical analysis of the survey responses was performed by Johns Hopkins Biostatistics Center, Johns Hopkins Bloomberg School of Public Health in Baltimore, Maryland. And the goal of the statistical analysis was to inform, again, an understanding of the patient experience, disease impact, and preferences for diagnosis and treatment. So now I would like to give you some key findings from this report. So a few of these key findings that really stood out to us were treatment protocols. So treatment protocols for primary tumor recommended by their doctor that successfully eradicated the primary tumor while sparing the eye and vision were extremely important to patients. Additionally, for genetic or molecular prognostic testing of the primary tumor for metastatic risk, patients overall desired reliable tests with low risk of side effects that can be performed locally by clinicians with expertise in their disease. And knowing the ocular melanoma space, we can say that not every state or region has a clinician with expertise in ocular melanoma. So that's a big one. Also, when it comes to following treatment of the primary tumor, patients prefer a surveillance protocol tailored in frequency and intensity to their risk of metastatic disease. And again, to know your risk for metastatic disease, there's a lot of things to factor in. But again, some of these prognostic testings that people cannot access across the country would be one of those areas in helping to identify that metastatic disease risk. When it comes to low out-of-pocket expense for genetic testing and treatments for primary tumors and metastatic disease was either somewhat or very important to our patients. And it was critically important to patients that their treatments for metastatic disease be prescribed and administered at first detection of metastases. So moving swiftly, coming up with that treatment plan that is amenable for both the clinician and the patient. Also, reduction in activities of daily living due to changes in vision affects approximately 1/3 of surveyed patients across all risk groups for metastatic disease. Approximately 1/2 of those at known risk for known high risk, for metastatic disease reported less ability to plan for the future because of the uncertainty of their disease progression. And the majority of respondents at various risks for metastatic disease, and especially those with metastatic disease, reported occasional dependence on spouse, partner, child, or caregiver. The frequency of self-reported anxiety of patients exceeded that of the general population, which makes a lot of sense. So I'm going to now review with you pieces of the executive summary. The report that came out was about 60 pages long. I did not include all 60 pages, but the MRF team will be working to distribute that report, get it up on our website so everyone can see the full outtake of the report. So here are just a few things that I've pulled out to share with you guys today. So first off, most patient respondents received eye-preserving treatment, RT or brachytherapy, for their primary tumor, with just 12 of the 128 respondents, or 9.375%, indicating that their initial treatment was inoculation. The responses to the survey demonstrated that most recently diagnosed patients had a biopsy and or genetic testing for metastatic risk assessment. Wow, I've got swollen tongue today or something. While patient understanding of their risk for metastatic has clearly improved since newly developed assessments with greater predictive value have reached clinical practice. But inconsistencies still exist in patient awareness of their risk, despite availability of the testing. In fact, approximately 25% of patients for whom testing was widely available responded that their risk was still unknown. And approximately 1/3 of patients across disease status and risk groups reported seeking care from providers outside of their geographic areas. And again, that goes back to the lack and disparity in disease experts in the OM space throughout the country. So we had 31.4% were low risk respondents, 35.3% were unknown risk respondents, 35.7% were metastatic respondents, and 40% were at high risk for metastases of their respondents. So I wanted to share a few open-ended responses from patients, which suggest that patients may face difficulties in securing coverage for follow-up appointments and imaging studies, ensuring that their clinicians are aware of and following the standard of care, which I know is a little lacking in the OM community. So a few of these respondents says, it feels like there are no resources for having to travel and lodge, but I probably don't qualify anyways because my salary is above poverty level. Well, we know that it doesn't matter if your salary is above poverty level, that everyone, cancer can be very expensive. And yes, those below the poverty level and at the poverty level need more help, but still we need access for all patients. Another said, I want to be able to choose the doctor and location of the treatment I desire when needed for survival. And this report showed that not everyone has access to an OM specialist, to an OM clinical trial, or even a treatment if they're living in more rural areas. Another said surgery and follow-up was in New York City for the first 5 years. They were from Virginia. It required travel expenses. They moved to Raleigh, North Carolina, and now they go to Duke. And so now they have to travel less. They're able to go to Duke to be there. But again, they had to move in order to be near that treatment center, which is something that we need to fix. And then last, currently, health insurance companies do not have OM on their list of prognoses, and the need for follow-ups to be more frequent than 1 to 5 years after a 2-year period. They evaluate in the same as melanoma skin cancer. So true. We need health insurances to understand that some of these things that are even FDA approved are still not considered as they're considering are investigational and therefore not covering it for the OM community. So over a quarter of respondents across risk groups reported they have reduced their daily activities due to UM, with individuals in unknown risk groups most frequently reporting this impact. Individuals with and at high risk of metastatic disease reported experiencing a sense of uncertainty in planning for the future, 50% and 60% respectively. UM patients struggling with anxiety and or depression, the impact on quality life can be profound. Several participants reported an unmet need with respect to addressing the psychological impact on their disease. Some respondent comments on these psychological or psychosocial impact of OM state, OM patients should not have to wait for results of scans. I am beyond anxiety after 7 years of meds, but early on, the waiting was unbearable. As a cancer patient myself, having 3 different cancers and, especially those in the rare disease space, it is a lot of anxiety and also called scanxiety of waiting to see whether or not you're stable, whether or not you've spread, or whether or not you're no evidence of disease. And so a faster process there would be certainly very helpful. Another stated working with a social worker and being referred to young adult cancer support group seemed like that was very helpful. There are cancer support groups out there. I know our friends at Colorado Retina host one as well. And there are a lot of virtual ones. You can absolutely touch base with our folks here and staff here at the Melanoma Research Foundation. We'd be more than happy to work with you to help find a support area for you. Another person said, I think a mental health support should be part of the treatment from day one. Losing a major organ like an eye is very traumatic. Would help deal with day-to-day living, including work. In the end, I was treated for depression a few years later. And lastly, my greatest anxiety was being 6 years shy of Medicare age and having a serious illness. My brother died of multiple myeloma when he was my age now. He often said he felt like digging a hole and burying himself with all of his medical bills. I can see now how he felt. It breaks my heart. So moving on, as expected, there was near unanimous agreement among participants on the importance of reliability and tests used to predict disease progression or likely response to treatment. And after test reliability, the attribute most frequently characterized as important was low risk side effects, with 85.9% of overall participants assessing this as an important factor. I mean, and clearly patients continue to struggle with coverage for prognostic genetic testing, and we need to change that. One respondent commented, I had to fight very hard for my insurance to cover my genetic biopsy. I was denied and appealed 3 times and sent to arbitration before they would cover it. The biopsy results were the guiding principles of my treatment. And again, as patients, you have better things to do with your time than have 3 appeals. You're worrying about the stress that's on you for your treatment, the anxiety, and many other things, and even affording treatments and your diagnosis in general. So you have a lot to worry about. This is one thing that patients shouldn't have to worry about. So the conclusion. The survey of patients revealed multiple factors that are important to patients when making decisions about treatments and wait and see surveillance for So A, successful removal of the tumor through an effective primary treatment, reliable, accurate genetic biomarker testing that can be performed locally by clinicians experienced in treating follow-up to primary treatment with surveillance regimen tailored in frequency and intensity to the patient's risk of metastatic disease. Effective treatments for metastatic that can be prescribed and administered at first detection of metastases. Newly diagnosed patients are not always informed that genetic biomarker testing is available. And if you are not informed by it, I urge you to become educated on it if you aren't already, and advocate. Ask the questions, and we are here to help you. We can provide a list of questions for you to ask at diagnosis, and then again, if you are presented with a diagnosis of metastases. And then we also learned that even when genetic biomarker testing is performed, patients may not always understand the results or the test or their risk of metastatic disease. So again, it's in making sure that your clinicians are educated about what all of that means. They're educated in having that conversation with patients, and that patients are also educated in knowing the right questions to ask when presented with that. And again, having a list of those questions prepared can really be helpful, because getting a diagnosis, whether it's metastasis or your initial cancer diagnosis, is never easy and oftentimes overwhelming. So we can help you be prepared here at the MRF. So in continuation of the conclusion, recent advancements in the understanding of as well as the ability to accurately assess metastatic risk, offer hope for improved outcomes in approximately 50% of patients who will develop metastatic disease. There are, however, potential hurdles to ensuring that all patients have the primary treatment, genetic testing, follow-up imaging, and treatment to address patient-specific risks, and a metastatic disease treatment that offers the best chance for improved survival. So these would be coverage for biomarker testing, which may vary by payer and require patients to go through multiple appeals processes to secure coverage, which again can be such a burden on the patient. Coverage mechanisms like Medicare could have the unintended consequence of deterring clinicians from offering the test and reduce Medicare patient access to follow-up surveillance based on individual patient and clinician decisions. Another disparity is adjuvant treatment options within clinical trials are unavailable to most high-risk patients due to the limited number of studies and sites, as well as clinical trial inclusion and exclusion criteria limiting enrollment of patients within a 6-month window following a primary treatment. And although, although clinical trial participation is recommended for patients with metastatic the small set of interventional studies recruiting US patients are clustered in a limited number of sites. Patients unable to afford traveling from home multiple times or for extended periods will not have access to this level of care, and that is a problem. Sharing and how, so in continuing this conclusion, how can we go about to start evoking change in these areas? So the most important thing we can do right now is sharing your patient experience, which can inform shared decision-making, clinical guideline development, and health policy. And so you're gonna ask, how can I do that? So the first way is become an advocate. Work with a patient organization like the Melanoma Research Foundation to understand what some of these barriers are and how we can go about fixing them. One of the things that the ocular melanoma and uveal melanoma communities did in 2020 was we got together, we went to the FDA for a patient-led FDA listening session. And this is where patients were able to talk about their grievances, share their patient experience, the impact of melanoma on their life, in order to have those clinicians, those researchers, and the people that run the different divisions in the FDA understand what is happening within the melanoma community. We also launched a registry, which everyone is very aware of. It's the Vision Registry. So participating in the Vision Registry to give that feedback of your patient journey so we can share that with clinicians, the FDA, and other health organizations that can help drive better access and standards forward. I do believe they're going to be planning another listening session within the FDA as well. So make sure that you keep your eyes and ears out for that. Working with the Institute of Clinical and Economic Review is another way to push back. And this report that we have administered and we'll be putting out, the patient-oriented value report, we plan to send that over to ICER as well. For those of you who don't know ICER, I will explain briefly what they are, but again, giving them your patient experience is another important way to drive better outcomes. So the US health system is distinctly innovative, but fails to provide high value care for all patients at a price they and the nation can afford. To improve access and affordability while retaining the incentives necessary for future innovation, ICER, or the Institute of Clinical and Economic Review, transparently reviews all available evidence to help align a treatment's price and access with how well it improves the lives of a patient and their family. Now, they do this by providing what they call equality or equality of life. ICER right now, and what they're trying to fix, is that they provide a higher quality of life number to somebody who is in good health, leaving the lower quality of life or value risk assessment framework on those with disabilities like cancer, like ocular melanoma. And so therefore the price adjustments and access are not very equitable. I recommend you go to the ICER website to learn more about how they provide quality of life to the US population. Lastly, share your patient experience with ICER's patient engagement team. You can go onto their website. They welcome the opportunity to engage with patient and consumer advocacy organizations to help people understand ICER and its role in the US healthcare system, as well as provide practical information on how to participate in ICER assessment for specific healthcare innovations. So again, this whole value assessment, value report will be sent over to ICER in hopes that we can get a meeting with them to again expand upon the report and bring patients to the center of what they do with the patient experience so they can understand the value and properly assess the value of a patient's life equitably so we can provide access to drugs that are even approved but still sit in insurance as investigative and therefore not giving approval without several appeals. And that will do it for me. I want to thank you guys very much for taking the time to attend these sessions today and to attend this session and listen in. If you have any questions, please email education@melanoma.org. And Amy Marble will be able to assist you and give you a little bit more guidance on any questions you have regarding these slides. Again, thank you, everything. Please don't forget to advocate for access, advocate for better outcomes, and share your experience often and wide. Your experience is really going to drive better outcomes. Thank you.
Thank you so much, Cassie. So much information there, so much great data that's going to help the ocular melanoma community. So thank you so much for that great presentation and for sharing all of that information with us today. If you want to be involved in our advocacy efforts, as Cassie mentioned, you can email education@melanoma.org. We have our virtual advocacy days coming up in March. It's going to be March 7 through 11. They are virtual, so you can participate from anywhere in the country, and we will connect you with your lawmakers after you go through a 2-day training. So we're really excited about that, and the save the date is going out shortly. I also want to thank Sarah and Rich for your wonderful presentation earlier. And again, thank you all for joining us. We are going to convene again tomorrow, starting at 11 a.m. Eastern. Great topics tomorrow. Again, make sure you're tuning in. We have a discussion on new drugs for metastatic melanoma patients. A lot of fantastic things in the pipeline, a lot of pending FDA approvals that we're really excited about, updates on clinical trials, again, some great science that's happening that you can find out about, enroll in. And again, we're going to look back at the last 10 years of the CureOM initiative and some of the things that have happened over the last 10 years, great progress that has been made, but also looking forward to the next 10 and where we want to go. So on behalf of the team at the MRF, we just thank you so much for joining us today. Again, patients are at the center of everything we do. We invite you to reach out if you have questions, concerns, programs that you think we need to be involved in, if there are needs, especially unmet needs in the ocular melanoma community that you think the MRF as an advocacy organization could partake in. We want to know that, and we want to hear from you. So again, our door is always open. We appreciate the OM community, and we appreciate the support you give the MRF all through the year as well. And we really look forward to tomorrow and the great information and topics that we're going to be highlighting. So again, thank you to all of you, and especially to our sponsors for investing in this really important meeting for the OM patient community. Thank you again, and have a great rest of your day.